All right, thank you. Really wonderful talk. Please stay online. Then, well, I think question can come towards the end. Let's next we have Dr. Ken Gersing from NCATS. So he's gonna talk about the N3C data integration model. He's overseeing. Ken, go ahead. Just we're gonna change the slides. And, this. Okay. Slides coming.
Oh, it's coming. So I shouldn't say a pregnant pause joke. My girls are moaning already. There you go. Perfect. Thank you. Okay. If I click this at you, yeah. Oh, there it goes. Oh. Okay. Well, first of all, it's always a pleasure to be invited to talk about N3C or other things I work on. My name is Dr. Gersing. I'm a director of Informatics at NCATS, and I think I was invited here to talk about the potential for a large maternal health, or I'm going to say women's health. We'll talk about that in a second. Repository. So I thought I'd give you a little background on N3C, and but think about in the context of what you'd like to do, or if this would be of value for potentially a maternal health network. N3C was started 4 years ago in 1 month. Right now we have 22.6 million patients, covering 90% of all counties in America. I guess it's 92% now. All 50 states, including Puerto Rico. There's 33 billion rows of data in N3C. Every Friday night, the new data sets are harmonized and it's put out on a new version on Monday morning. Right now, we have 3,900 concurrent investigators. There's 555 current studies, and the population is very well represented across the country as far as it matches census well. Most of the data is outpatient. It's 80% outpatient. So one thing that's a little unusual about N3C is that in the context of COVID, we decided to do a centralized repository. So sometimes when you hear about repositories, data models like Sentinel that we just heard about, or OMOP, or ACT, or COREnet, you basically send a question to the institution and they give you back usually aggregate counts. But in the case of COVID, it was going so quickly that we felt that people needed to be able to iterate over the line level data. And so we harmonized all the data that comes into N3C. And so when it comes from 84 institutions, that data comes in lots of different flavors. And for you all who aren't a pocket protector carrying member of the stylish society like I am, if you think of a common data model as a language, a language instead of ACT or Trinetics or the Cornet or OMOP, you could just say French or Spanish. And so in the case of COVID, we said to the institutions, like I said now 84, give us it to us any language you want, and we'll clean it up and harmonize it. That means we had to combine it into a single analytic set, and we decided to use OMOP as the analytic set. Truth is, we could have used any of them. We used OMOP because it's the largest and has the biggest community. And we're also working on FHIR, and I'll talk about that a little bit later. So sometimes people say, well, what was successful at N3C? What was not successful? And I want to stop here and just kind of at the 20,000-foot level, talk about governance and why it's so important. So between the institutions using the data, I think I was 300 and something, 90, I think is what it was, and contributing the data to 84, we have almost 500 people who have signed a contract with the NCATS, the federal government, to host their data. Now, we don't own the data, we're stewards of the data, and anybody can take the data back if they want time, but the idea of trust in using data is central to being able to pull this off. And the other thing that's central is that it's a data use agreement, 2 pages, and a data transfer agreement, 2 pages. So it's simple, it's not changeable. Everybody signed the exact same agreement. And this is really important if you ever want to pull off a national network, because you can't negotiate with each institution, especially during COVID. That was just not going to happen. So just as I get through this slide, the data contributors give us the data as a limited data set. So unlike some data, it does have true dates and true zips. And it comes to us and we clean it up, like I just said, and we make it into 3 flavors: a synthetic data set, a de-identified set, not safe harbor, de-identified, because we're under the common rule, not under HIPAA, and a limited data set. And then on the bottom up, if you wanted to get access to the data, your institution signed a data use agreement, and you come in and you apply, and you submit 2 paragraphs, 1 title, and you go through a DAC and you get access to the data usually within less than 7 days. If the DAC says, look, you don't really need limited data set, they'll bump you down to de-identified, but it's never about your science. It's about minimum necessary. The other thing that we did is that we pay for the entire N3C is in an AWS FedRAMP moderate cloud. We pay for all tools, all the data goes in there, but data cannot go out. So again, I just keep circling around this idea of trust and data quality, which I'll talk about more in a second. But we have dual authentication, we give you all the tools you need, we pay for all the GPU, but it just wouldn't happen if the institutions thought we were going to not control this data. And so I just can't emphasize that enough, why I think that's so important if you're going to try to do something centralized. So I want to switch topics to EHR data. And I think that a technical term to describe EHR data is horrible. I have been doing this for 30 years, and it is, I think we all know that EHRs weren't designed for research. They weren't actually designed for clinical care. They were really designed for billing, right? And regulatory compliance. And so you are asking a lot of to be able to use this for research. And the reason I want to bring this up is a couple of reasons of incompleteness, and we're going to talk about that more in a second, but just how much cleanup has to be used in a data. And in the previous talk, talked about cleaning up data. The green line are units of measures on labs in N3C that are correct. The blue are incorrect lab units. Half of the labs we get in N3C are wrong units, and we can clean up most of them. The dark green is just converting to something common, so everybody's in kilograms, everybody's in pounds, or whatever we decide to do. But literally the blue is wrong. So can you trust the data if you don't spend an enormous time getting it research ready? And I would say no. I think it's not fun, but it's really important. The other thing that's less obvious is that we're doing federated data. I think I'm going to take a step back. Federated networks have things that centralized do not have. The security issues I'm talking about just don't exist. But there's also some downsides. And this is one of the ones that worries me the most. How people at institutions define things like a visit are actually different. And I'll give you the example I always think about is that we have patients in N3C who are in the ICU, intubated, who have outpatient visits. Now, how is that possible? I mean, you don't see people walking around with intubated that often, right? But they're there. Well, what happens is when they're wheeled down to get a chest X-ray, they go to an outpatient clinic. And so they are recorded as an outpatient visit. So it's not that they actually walked out of the hospital with their ventilator, because there's not a big market for them, by the way, on the black market, especially dirty ones. But if we don't know that they're all defined differently, and that you say, oh, this person's visit was only 5 days at XY institution because he must have been out of outpatient because it was an outpatient visit, and therefore you have 2 episodes of care, then you would actually be comparing apples and oranges. So the problem we don't actually know how institutions define simple things as a stay, a length of stay. And so one of the things that's helpful, especially in the pandemic, is we had to get our things aligned correctly. The other thing is that you can imagine that, actually, can I go forward and backwards? Oh, watch. Yeah. Oh, yeah, it did work. Okay. Let me go forward one. So way before COVID, starting in 2017, when I came to the federal government, I'm from Duke, and Rob Califf happened to be the commissioner at his first round, and he has a very deep baritone voice. And he called me when I worked at NCATS, and he said, "Ken, I can't use the data; it's terrible." And so what was really happening is that people were mapping models 1-to-1. So I will map Sentinel to OMOP, and then I will map OMOP to PCORNet, and then PCORNet will update it, and so then all my mappings are wrong because they just updated something. And it was this constant chasing your tail. And right now, I know of at least 24 funded efforts to map FHIR to OMOP, 24 federally funded instances to do this. So we all know all 24 are wrong because they're all different. So somebody's wrong in them. So we said, well, that's not going to work. And so we partnered with FDA and NCI, ONC, and there's something that I want to talk about. It's the NCI CADSR, and it's a metathesaurus. And the way the metathesaurus works is that there's semantic matches. And I hope this makes sense to you on this one. So, I think these are made up, so don't trust that they're actually true. But I just want as an example. So let's say you were PCORNet, and male was in a column called sex, and male was M. And then you were in OMOP, and the gender concept code was 8507 for male, right? So, you would want to map them together. But if you mapped them 1-to-1, you're always at risk that if something changes for every reason, you broke in it. But in the CADSR, we map PCORI to the semantic hub, the meaning of sex, right? Whether the name was correct or not. And then we map OMA to the semantic hub. And then automatically, I had 2 little girls, they're not little anymore, but that's a magic wand for my daughter, Margot, when we went to Disney World. We hit the little bubble, and automatically M is equal to 8507. And that's really a numerically an incredibly powerful thing. So that allows us to keep mappings up to date, fix them asymmetrically, and version them so we always know who's using what. So when we go to reproduce the data, we know this is the mappings you were using at this time. And all these mappings are maintained in the CADSR. And it wouldn't be possible if it wasn't for the generosity of NCI to do this. So the other thing that we found out in EHRs, this is not surprising, is because of their incompleteness, I would say that EHR data is unique. We have to use it. It has values, lab results that claims don't have, but it's really quite inadequate to come up with impactful statements. So right at the beginning of COVID, we started working with Sean, who's somewhere on an airplane right now, and Sean Granis, about linking data. Actually, it was Umberto at the time. And so we link N3C data to CMS data, Medicaid, Medicare, viral variants from different state departments. Mortality data, we don't use in National Death Index because it's so old. It's a year and a half old, and it's incredibly expensive. We buy that data for about $250,000 a year, and it's only 3 weeks old. It's actually a good deal, right? N3C data, vaccine data from 9 states, imaging data, and recently we were start bringing in registry data. And if you don't know what PPRL is, it's a de-identified linkage. That means that there is no PII passing through. It's really important that people understand that. The other thing we do is we link it to social determinants of health. And the reason I really shouldn't put this on this slide, but then I'd have to have 2 slides. It's for social determinants of health, we bring in public data sets. And so we know what highway you're living where. So there's a pollution index, and we know if there's a food desert, and there's about 60 repositories that we clean up and maintain as just dictionaries within the system. So you can link your data in person to person with the PPRL, or you can link it more on a zip code level, the social determinants of health. And just to give people comfort, because I know this can upset, reasonably upset people. If John, I live in the triangle, that's what I'm using, Duke and UNC, and it's only 4 letters and I can spell it. So John went to the ICU at Duke, and Duke misentered his name with an H, John with an H. And then but he gets his daily care at UNC. Same dates of birth, but different names. When the PPRL goes over, he's 123, it's actually a much longer number, from Duke, and he's 456 from UNC. So they're different numbers. Now, why is that important? Because if there's a break-in at UNC or at Duke, you can't match them. The only people can match them is actually Regenstrife. And so they matched them, and they found both 123 and 456. Our real number is 007. Honest Broker has no PII, and then we get the link and we glue all those things together. So nobody has any PHI. Interestingly enough, if you want to go backwards and start recruiting people, you could say, send to University of Iowa or Duke and say, this is that magic number you gave us, only you can decrypt it, but we're interested in recruiting this person if you want to be studies. The other thing I want to talk to you about, just a little bit about hashing, is it's not one hash. We use 18 hashes, and it's the combination of the confidence that says we know that this is John Doe. And one thing that was really nice is that Regenstrife has access to IHI data, the Health Information Exchange of Indiana, and therefore we were able to do validation and know that this is true. So why is this important? Because we're talking about mommy baby, right? So I just want to talk about just the role of the honest broker. It's very important for the federal government, given tense times that we're all trying to misuse data, that there's an indirect. And so the honest broker serves as kind of an indirect to, again, help that trust issue that I keep talking about. So I was talking kind of like the auto magic with data, but there's also auto magic with linkage. So we bring in data from CMS and N3C, but we also bring in data from all of us and SEER. And then even though, let's say we brought in data from mortality and CMS, and I paid for mortality and CMS, but all of us gave us their data, then they actually can use our mortality and our CMS and tell how many people are in all of us and CMS, because we're just matching these hashes. So that's kind of cool, isn't it? Then we can say, well, really, who across the country, is it all of us, has both people with this population I'm going to look for, and that's a data set I want to target and use. And I don't have to actually get their PII. I can actually know what's there. And I don't have to go to an IRB because we're just matching numbers. It's kind of cool. Okay, so this is where we're going and why we're doing this. So for you all aren't familiar, the CTSA is quite large. It's the largest grant every year at the NIH. It's approaching $700 million a year. There's 60, 1, 2, 3, depending on who's in, who's out, institutions that are at any one time getting funding. And we can't afford to fund informatics across 62 health institutions anymore. It's actually not 62 or 3 because, again, at Duke has 3 hospitals. UNC has 4 hospitals. We've eaten most of the private practices in North Carolina. We're getting data from all across the state, but this is true of it didn't have to be Duke or UNC, it's everywhere, right? And so these are really quite large systems. So how are we going to reproduce N3C, not in a crisis, and maybe use it for something like maternal health? So I'm a psychiatrist by training, but I see myself more as a plumber now. As a plumber, I want to build a house, an apartment building that anybody can use. And that's what N3C really is. And it was always built this way. We, the federal government, supply the ventilation and the plumbing and the electrical. We don't know what's going to go in it, right? But in more research terms, we supply governance, because this is how you're going to use the data. This is how you're not going to abuse the data. You promised us. You've signed this, and your institution. We do all the harmonization. We do all the quality. We give you all the tools. We give you workbooks. We give you R. We give you analysis. Haven't even done anything yet. It's just there in this empty building. And then you come along and you say, I've got this house I want to build. And it's the maternal health house. And it's going to have maternal health data in it. And I say, great. Where do you want to get your data? Let's figure out where your data is coming from, how we're going to clean it up, how we're going to harmonize it. And we will do that for you. And so we take those houses. And by the way, these are all modular houses. Aren't they beautiful? They're built in factories. And we link all that data, right? That's our job. And then we take that modular house, and you can see this, that's supposed to be a little truck. We put the cancer tenant or renal or tenant on a truck, and we port it over to NCATS, and we stick it into my big building. And it just kind of plugs in, right? Because everybody's going to use the same plumbing and the same electricity. Well, this is an enormous benefit in costs, because everything I've set up, I can actually produce one of these new enclaves to do research in less than a couple hours. I just hit the button and it takes everything that we produce and just gives it a new name. Not bad. So our cost really is getting people to sign the contracts that allow us to use the data. So this is actually what we're doing right now. So we took N3C and we made a copy of it, not the data, just the stuff, the tools in it. And we are now partnering with NCI and other groups, and we're having a cancer enclave. And so what's unusual about this is that UNC, this is all fake, UNC doesn't give us data on cancer. They give us their entire EHR, everything, okay? And it's de-identified. And we do that whole cleanup thing. We make Emma male, and Johns Hopkins did the same thing. We make pounds and kilograms, and Nebraska did the same thing, and we make Fahrenheit to centigrade. It's all clean. Nobody can touch it. It's hidden. It's sequestered. And then NCI said, we want to do a cancer study. And so we write a phenotype, and we say, everybody raises their hand who wants to play in cancer. Turns out UNC and Johns Hopkins wants to play in cancer. The phenotype that is created by the scientists pulls the data into their private box, and they're ready to go. So right now, I know I've got 1.5 million people in N3C COVID that have been pregnant and had a baby, right? So we could pull those people out of it and stick it in a mommy baby box. Doesn't matter. And then same thing, Johns Hopkins, we have another one, which is true, funded by NIDDK and ASPE, and Johns Hopkins raised their hand. They're kind of greedy. And in Nebraska says we want to play in that one, renal query, pull it over into the renal box, right? And those boxes, those research boxes are ephemeral, meaning that they're temporary. So this is really important because we have to figure out how to really protect this data. And so if it's maternal health, mommy baby data, And we're worried we could make a contract that says at the end of the study that you guys design on September 1st, 2026, poof, we blow this away. We never want this data to be used for any other purpose because you guys decided that, because you're the leads of the apartment building. You design the house, right? And there's the maternal health enclave right there. And these are the different ones, and they've all got different rules on them. Within the parameters of what we want to do, you can dance any way you want. It can be an open enclave where anybody can get in. It can be a closed enclave because, you know, UNC and Duke don't like each other because they have different basketball colors or whatever, right? It's up to you guys to decide. Now, it's you know that old expression, any color as long as it's black. We're kind of like that, but it's not just black. We do orange and gold and purple, but it's not every color. But you know, open or closed, linked or not linked. But I do want to, I thought I had to think of something wise to say. So this is my wise moment. Get ready. So I'm really worried. I never thought I would say this, but you know, obviously the United States is very polarized right now. And the NIH and other groups are very worried about studying mommy baby. And I think you guys probably know this because they're worried, and both sides are worried that it's going to be abused or how are we going to use it. And I feel like we have an opportunity whenever we do these things to try to think about both sides and figure out a common ground that we all agree how the rules are going to be. And I think we've got to do that first because this one particularly is so tough the only thing I guess my take home is that technologically now, this is a slam dunk. We've been practicing this for 4 years. It's not a slam dunk governance wise. And I think that's where I challenge everybody to figure out how we pull this off so that we don't make sure this data is well used. And that's it.
Thank you, Joe.
Sorry, sit down.